All right, let's get right into it. We're going to talk about the single most common reason people get rushed into emergency abdominal surgery, anywhere in the world. And for this breakdown, we're pulling our facts from one of the absolute Bibles of medicine, Harrison's Principles of Internal Medicine.
So why should this matter to you? Well, look at this number, 9%. That is the lifetime risk for men. For women, it's a little lower, around 7%. The point is, this isn't some rare, bizarre condition. It's something that's common enough that it's absolutely worth understanding how it works.
And while it can happen to anyone in any age, it definitely has a favorite target. We see it most often in teenagers and young adults, with the peak age hitting between 10 and 19 years old. So let's start with the absolute basics. So what even is the appendix? Well, it's this little finger-shaped pouch that just kind of hangs off your large intestine. Most of the time, it's located in the lower right part of your belly. But, and this is a huge but for doctors, it doesn't always stay put. Its position can actually vary a ton. Sometimes it's tucked behind the colon, other times it's way down in the pelvis, which, you can imagine, can make figuring things out pretty tricky.
Okay, so how does this seemingly random little organ suddenly turn into a ticking time bomb? Well, the whole dangerous process, this entire chain reaction, gets kicked off by one simple event, a blockage.
And it's pretty amazing just how quickly one thing leads to the next. So step 1, the opening gets plugged up. Step 2, all the normal, harmless bacteria living inside get trapped. With nowhere to go, they start to multiply like crazy. Think of it like a party in a sealed room. And the pressure inside just skyrockets. Step 3, that intense pressure starts to squeeze the blood vessels in the appendix wall, cutting off its own blood supply. That's a condition called ischemia. And finally, step 4. Starved of blood and oxygen, the wall gets weak, it gives out, and it bursts. That, right there, is a perforation.
So, what's actually causing that initial blockage? Well, the number one culprit is something called a fecalith, which is just a fancy medical term for a small, rock-hard piece of stool. In younger people, another really common cause is lymphoid hyperplasia. That's just swollen lymph tissue, the kind of thing you might get after a viral infection or a stomach bug. And, much less commonly, the blockage could even be caused by a tumor.
And this brings us to one of the most unique things about appendicitis, what doctors call its classic story. You see, the sequence of the symptoms, how they appear and change over time, is like a narrative, and it's one of the single biggest clues for a doctor that they're dealing with appendicitis. This timeline pretty much tells that whole story. Act 1 almost always starts with this dull, vague, kind of crampy pain right around the belly button. Then, over the next 12 to 24 hours, the plot thickens. The pain does something very, very specific. It migrates. It travels down and over to the right. And as that appendix gets angrier and starts to irritate the lining of the abdomen, that vague ache transforms into a sharp, constant, you can point to it with one finger kind of pain.
And here is another huge clue in the story: appetite, or more accurately, the total lack of it. Anorexia is an almost universal symptom. It's so reliable, in fact, that Harrison's makes this incredibly direct statement. The diagnosis should be questioned if the patient still has an appetite. It's just that consistent.
Okay, so the patient's story is pointing right at appendicitis. How does a doctor go from a strong suspicion to being certain? It's really a three-pronged approach. You've got the hands-on physical exam, some key lab tests, and finally, medical imaging.
This is where the art of medicine really comes into play. A doctor is going to check for tenderness at what's called McBurney's point, a very specific spot in the lower right abdomen. They'll also test for Rovsing's sign, which is this weird thing where pressing on the left side actually causes pain on the right. Then you have the psoas and obturator signs. These are special leg maneuvers that can hint at whether that appendix is hiding in one of those tricky spots we talked about earlier.
Next up, the lab work adds another piece to the puzzle. You'll almost always see a higher than normal white blood cell count, but the real giveaway is something called a left shift. All this really means is that the body's immune system is working so hard, it's sending out brand new, immature white blood cells from the bone marrow before they're even fully ready. It's a classic sign of a serious bacterial infection. And finally, we move from the art of medicine to the hard science, the CT scan. It is the gold standard for a reason. We're talking accuracy rates over 94%. This gives doctors a direct look at what's going on, and they're looking for an appendix that's swollen to more than 6 millimeters thick. In a lot of cases, this is the final, definitive piece of evidence.
So the diagnosis is confirmed. Now the clock is officially ticking. The main goal is to get this problem fixed before it spirals into something much, much worse. So let's talk about the treatment.
And why the big rush? Because in about 1 out of every 5 cases, the appendix actually ruptures, and that risk is even higher for young kids and older adults. A rupture means all that infectious material spills out into the abdomen. Best case scenario, the body walls it off into a contained pocket called an abscess. Worst case scenario, it leads to peritonitis, a widespread and very life-threatening infection.
For a very long time, the solution was simple: surgery. And today, a minimally invasive procedure called a laparoscopic appendectomy is still the gold standard. But, and this is interesting, the story is changing. For simple, straightforward cases, there's a lot of new evidence showing that antibiotics alone might be enough. In fact, for the right patients, this approach can help up to 70% of them avoid an operation for at least a year.
But what about those more complicated cases, where the appendix has already burst and formed a big abscess? Then you have to change the game plan. Rushing straight to surgery can actually be pretty risky. So the strategy is often to cool things down first. You drain the abscess, put the patient on powerful antibiotics, and then, once all the inflammation is gone, usually 6 to 12 weeks later, you go back in for what's called an interval appendectomy. So what's the big takeaway from all this? Appendicitis often follows that classic story: the pain that moves, the loss of appetite. But the most important thing to remember is that it doesn't always follow the script. It's a master of disguise. It can mimic dozens of other conditions, from kidney stones to ovarian cysts. And that leaves us with the real challenge for doctors. In a race against the clock, being able to piece together all these clues to make a fast, accurate diagnosis isn't just important, it's everything.